From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm your host, Dr. Mary McDermott, Professor of Medicine at Northwestern and JAMA Deputy Editor. Today, I am joined by Dr. Naomi M, who is Professor and Vice Chair in the Department of Psychiatry at the NYU Grossman School of Medicine. Welcome, Dr. Simon, to this JAMA podcast.
Pleasure to be here.
So your review covers the diagnosis and treatment of anxiety disorders. And perhaps we could start by having you summarize how common these disorders are and what are the most common types.
Anxiety disorders are highly prevalent, and data from the National Epidemiologic Survey on Alcohol and Related Conditions, which occurred about a decade ago, suggests just under 13% of people in the United States are affected over a 12-month period. Our next biggest epidemiologic survey was the 2004 National Comorbidity Study, and that showed a lifetime prevalence of 34%.
And what are the typical presenting symptoms of anxiety disorders?
Well, anxiety disorders can present with both psychological type symptoms and physical symptoms. So common symptoms are feelings of anxiety, nervousness, fear, and worry. But physical symptoms are also present, and sometimes people will present primarily with those, such as heart pounding, palpitations, feeling short of breath, dizziness, lightheaded, and muscle tension. These symptoms can be a little confusing because they're also symptoms that can occur under stressful situations. We do need to inquire more to understand whether an anxiety disorder is present.
Right. And so can you provide some advice for the primary care physician about how to distinguish between normal everyday anxiety from the stresses of daily life versus a medical disorder that requires treatment?
Yes, this is where taking a history comes in to try to understand how long the symptoms have been present and if they're persistent and if they cluster together. And fortunately, there are ways to do screening as well using evidence-based assessments such as the Generalized Anxiety Disorder 7, the GAD-7 that is commonly used. There are many other disorder-specific measures. The Generalized Anxiety Disorder 7, or GAD-7, is a 7-question self-report measure of general anxiety symptoms, and it can be used to screen for generalized anxiety disorder or as a first-level screener for any anxiety disorder. But I think the first thing in questioning a patient is to try to understand what is the severity, persistence, and clustering of the symptoms, how they come together. And we can certainly talk about that more across how that occurs in different anxiety disorders. But if the symptoms are only occurring when one stressful event at work is occurring, for example, that doesn't define an anxiety disorder.
And so can you speak a little bit more to what you look for, a sign that there is something more than just everyday anxiety?
I think it might be helpful, one, to say that all anxiety disorders, there are two different sets of diagnostic criteria that are commonly used. Those in the ICD-10 or 11, the systems that are used for all of medicine. And then in psychiatry, we have what's called the DSM-5, the Diagnostic Statistical Manual of Mental Disorders, which have clustering of the conditions that come together. And in all those criteria, in order to meet criteria for a disorder, you have to meet the kind of time and persistence criteria. And also there need to be associated impact. The patient has to be significantly distressed and or there need to be clear functional impairments. So impairments in their social or their work life or school life or other important areas of functioning. I think to think about how the specific disorders could be identified, it's important to talk about what the common disorders are. 3 of the common disorders that we see and treat in primary care include panic disorder, which can occur with or without agoraphobia, and agoraphobia can also occur on its own, social anxiety disorder, and generalized anxiety disorder. So to explain a little bit about what those are, generalized anxiety disorder is a worry-based disorder where there's worry and nervousness associated with at least 3 other symptoms. These can include symptoms such as irritability and muscle tension, for example, but it's a general worry-based disorder that persists for at least 6 months and generally is quite chronic. It also has high rates of concomitant depression associated with it. Social anxiety disorder has an early age of onset on average. It can occur even as a child. It has one of the earliest ages of onset. But the median age of onset for anxiety disorders is actually age 11, and they tend to have a chronic course. In social anxiety disorder, like generalized anxiety disorder, the symptoms have to be present for at least 6 months. And the core symptoms are related to social and interpersonal anxiety, so nervousness about meeting new people, about talking socially in a group, as well as performance-related fears. So giving a presentation in front of a group or standing up in a theater and being part of a performance. There's also a performance-specific type of social anxiety disorder that's less generalized. So patients who only have significant difficulties, for example, if they need to make presentations, and that's differentiated in our treatment approach. And then there's panic disorder, which many primary care doctors are probably familiar with because patients can present to emergency rooms or call the office with a sudden onset of acute fear and anxiety that often will present with quite significant physical symptoms such as heart pounding, shortness of breath, chest tension, and patients may feel that they may be having a heart attack or some other medical problem. We do need, as clinicians, to be able to first do a differential diagnosis to make sure that there isn't an underlying medical cause of the anxiety symptoms that are presenting to us. But in panic disorder, what you see is acute onset of anxiety symptoms in a form of a panic attack that occurs suddenly within minutes. And then after that, at least a month of persistent anxiety or worry related to panic attacks or fear of panic attacks. And what can happen is those panic attacks can become tied to specific situations. And they're very typical kinds of situations where this will happen. And they become linked to become triggers. Patients will then often develop avoidance, but certainly fear of those situations. So typical kinds of situations could be being in enclosed places, being in public transportation where you wouldn't be able to get out quickly if you had a panic attack. Patients may report they're not comfortable anymore sitting in the middle of a movie theater, because they might have a panic attack if that were to occur. And patients can also become quite sensitized to those physical sensations themselves to the point that they avoid exercise or other things that might, for example, make their heart pound. So those are kind of the core primary anxiety disorders that we treat in primary care: social anxiety, generalized anxiety disorder, panic disorder, with or without agoraphobia. And agoraphobia represents that kind of core avoidance related to anxiety.
You mentioned earlier the GAD-7, and I wondered if you could let us know what you think the primary care clinician should know about using that in their practice.
There has been a lot of movement in recent years about increased screening for depression, but it's only more recent that attention has been coming to the need to screen for anxiety disorders in primary care as well. So if you think about the PHQ-9, the GAD-7 is like the PHQ-9 for anxiety disorders. So the PHQ-9, or Patient Health Questionnaire 9, is a 9-item self-report questionnaire that measures symptoms of depression. The GAD-7, if you can't manage to give patients 7 questions, there's even a shorter version, the GAD-2. And if you combine it with the PHQ-2, it's the PHQ-4. But all these acronyms aside, if you can give a generalized anxiety disorder 7 in practice, it has a sensitivity of around 57 to 94% and a specificity of 64 to 97% of detecting the presence of an anxiety disorder. However, what it doesn't do is say, are those impacts on persistence, distress, and impairment present? So if you have a patient who screens positive, you would still need to follow up with them to ask more questions, like when did those symptoms onset? How commonly are they present? Are they interfering with your day-to-day functioning in any way or causing you distress? And GAD-7 is often recommended as the first one because even though it's most specific to generalized anxiety disorder, it's pretty good at picking up the presence of some anxiety disorder. So if you're speaking to the patient to try and understand, is their primary issue worries or something else, that may help you to start to differentiate. And there is, just like with the GAD-7, very well validated measures that are self-report and brief for each of the anxiety disorders. So you can always give the patient additional measures if it's not clear which condition it is. And we feel it's very important to make that differential diagnosis, even though we know in psychiatry that in a primary care practice, you don't have a lot of time with the patient. Clinical guidelines recommend that you make a specific diagnosis. In primary care, often that doesn't happen, and many patients are not detected or diagnosed specifically with what their anxiety disorder is. And these scales can help improve that. Right now, like data suggests, less than half of anxiety disorders are detected correctly in primary care, and it's much less than that if you look at the specific diagnoses. The first thing to do as a recommended intervention for all anxiety disorders is to teach the patient that they have an anxiety disorder and what the anxiety disorder is. It might seem very obvious, but if you have an anxiety disorder in which you sort of learn to become very focused on your symptoms and worried about their meaning, like whether you're having a heart attack or whether you're going crazy when you experience these symptoms, which many patients will have those kinds of cognitions, explaining to them what it is, that it's common, how it typically presents. Like patients may come back and say, wow, I didn't realize other people experience this. That in and of itself, explaining that and that there are evidence-based treatments that are effective, available, can substantially decrease anxiety in and of itself. And it's the first thing to do, like the first step of all care, whether it be medication care or more sophisticated psychological therapies.
That's a good segue into treatment. Your review in JAMA discusses pharmacotherapy and also psychotherapy as both being important modalities to treat anxiety. So maybe let's begin with pharmacotherapy. What medications do you recommend for treating anxiety?
Well, the first line interventions for treating across the anxiety disorders, with the exception of the performance only type of social anxiety disorder, are the SSRI or SNRI antidepressant medications. So these are the serotonin selective reuptake inhibitors or the serotonin norepinephrine reuptake inhibitors. So these are the medications like sertraline as an SSRI or venlafaxine as an SNRI. And the reason for that is because of, one, the large amount of clinical studies and clinical trials that have been done across the anxiety disorders, and the fact that they'll also treat concomitant major depressive disorder, which can occur in up to half of patients with anxiety disorders, and also because they lack the abuse or dependence risk associated with benzodiazepines.
Is sertraline your first line for the SSRIs and venlafaxine for the SNRIs?
I really just provided those as examples. So amongst the SSRIs, there is very few studies, I would say, that have actually compared them directly by doing a clinical trial and seeing which one works better than the other one. So for the most part, they're thought to have comparable effect sizes. However, they do have different side effect profiles, and some of them, have different costs associated with them for sure. We tend to pick the ones that are a little bit less activating. So like fluoxetine might be more activating and have a little bit less data available for anxiety disorders, whereas citalopram, escitalopram, or sertraline are sort of in the middle of the road and have more data for anxiety disorders. Paroxetine also has a lot of data. Sometimes it can be a little bit sedating, but it's also a good medication for anxiety disorders amongst the SSRIs. Amongst the SNRIs, venlafaxine has the most data in clinical trials, with duloxetine being the other agent.
What is the role of benzodiazepines in the management of anxiety?
So this has been a question of great interest over the years. Clinical practice guidelines don't recommend benzodiazepines as a first-line intervention for anxiety disorders. It really doesn't have anything to do with the efficacy or effect sizes because benzodiazepines have some advantages over antidepressants in terms of their speed of onset, and they have a somewhat different side effect profile as well than the SSRI or SNRI antidepressants, but they also have other associated risks. So risks associated with benzodiazepines include abuse or dependence, particularly if there's a history of substance use disorders. And also the way that they are taken is important. So if they're taken on an as-needed basis, although they can be effective that way, and one condition that they could be potentially used that way is performance anxiety. But one thing that we do see in practice, unfortunately, is sometimes patients are only given an as-needed benzodiazepine, which is insufficient alone to occasionally take a benzodiazepine for the treatment of full anxiety disorder. But also, if they are taking it as needed all the time, it actually increases their attention to whether they need the benzodiazepine. And it can interfere as well with the cognitive behavioral therapy or unlearning those fears that happen. So it can create kind of a cycle where patients start to take benzodiazepines more often and become dependent on them in that way. So there are other obviously associated risks with risk of falling or cognitive effects of benzodiazepines, but it's really the risk profile that makes it not a first-line agent. They can be helpful also as adjunctive treatments for patients who are refractory. But again, we generally recommend in anxiety disorders that, with the exception of taking it for people who have a rare performance need and can manage it that way, that they be given as a standing dose.
I wonder if you can next give an overview of psychotherapy. In your review, you talk about the importance of cognitive behavioral therapy. And I wondered if you could review what that is with us and how it's used for anxiety.
So I think just to highlight that point, most practice guidelines do recommend cognitive behavioral therapy as a first-line intervention. So not just the type of psychotherapy with the greatest evidence base, but also first line alongside medication so that the choice of which approach can be made with a patient, including their interests, preference, and looking at the overall needs of the patient, like their level of comorbidity, medical comorbidities, severity, current and prior treatments, and so forth. Looking at their age, whether they're trying to become pregnant, what's their access to care, can they get in for treatments or not. So the first step is to decide with the patient what is the best approach, pharmacotherapy or a psychotherapy, with cognitive behavioral therapy being the first line treatment. And cognitive behavioral therapy has been shown across the anxiety disorders to have small to large effect sizes, but overall to be fairly comparable to our first line treatments. And one of the biggest problems we have is generally access to those interventions. But I think one thing to understand about cognitive behavioral therapy is that it is a short-term targeted intervention. So while there are some cross-diagnostic anxiety disorder interventions, there are also specific packages in the realm of 12 to 16 weeks that are developed with a rough protocol for clinicians to follow. And those are the ones that have been studied the most in randomized clinical trials. And the core elements of cognitive behavioral therapy, just to kind of break it down, first, it starts with that same, what we call psychoeducation or education about what is anxiety, what is the condition that you have, helping the patient to understand what's been happening with them so that they gain a better understanding of how to approach the symptoms that they have and their meaning. It also works with something we call cognitive restructuring, which is simply looking at thoughts and cognitions and trying to understand with the patient where they may be going off track or distorted. So, for example, as we talked about a patient who may be having physical anxiety symptoms that may make them think they're having a heart attack. If a patient is having panic attacks, you might talk with the patient about how many panic attacks they've had in their lifetime, what kinds of symptoms they've been having, and work with them around the logic. There are many ways to work with cognition and thinking. And then the other core aspect, which I think is actually really helpful for primary care doctors to understand, because if you are providing care, even if it's a pharmacotherapy care, you can kind of tip off of an understanding of what exposure-based interventions are. And what that is helping patients to go back into situations that they're avoiding. So for example, if you are a patient who had a panic attack when you're in public transportation and you start to avoid all public transportation, then the meaning of that public transportation and the likelihood that it is going to cause an anxiety attack the next time you go gets strengthened. So what we do is we work with patients to go back gradually from their least to the most feared situations. And we teach them that, of course, anyone who's had anxiety in that situation past, the first time they go, they're going to feel anxious. So we work with them to go and stay in the situation, even if they're anxious. And as they do this repeatedly, the anxiety goes down. And this is what we call exposure. And if you work with patients, even if they're being treated with an antidepressant, to start to go back into those situations, even if they are anxious, you're going to help them to decrease that functional impairment and actually to break that cycle and connection between the fear and the avoidance.
Dr. Simon, can you talk a little bit about the prognosis for patients with anxiety?
As I mentioned earlier, the disorders untreated tend to be chronic. There's some data, for example, it says that recovery rates from anxiety 12 years after initial evaluation are about 37 to 58%, but treated, about 45 to 65% will respond to that initial treatment. And that is defined as like having significant changes from baseline with the intervention, be it psychotherapy or pharmacotherapy. And patients who do respond to treatment, we want to keep treating until they can have a robust response. One of the things in clinical trials is the definitions have varied for response and remission. Remission is typically defined as no longer meeting those diagnostic criteria or not having enough significant symptoms that they're interfering or causing distress, similar to the thresholds. Not that you would have none, because we all experience some kinds of anxiety or nervousness or worry sometimes. If patients do achieve that higher quality response, that decreases the likelihood of relapse. And there is data, although there's not a lot of data about relapse, that patients do better if they're continued on their pharmacotherapy for at least a year. Patients who have relapse on cognitive behavioral therapy after stopping cognitive behavioral therapy, because that's a short-term treatment, they can also do better if you do even what we call brief booster sessions, so to work with them to reinforce what they've learned in the past.
Thanks for listening. I'm Mary McDermott, Deputy Editor of JAMA. I've been speaking today with Dr. Naomi Simon of New York University about the diagnosis and management of anxiety disorders. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Lisa Hardin, Audrey Foreman, and Mary Lynn Fergaluk. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.